Welcome to the Deep Dive. We're the podcast that helps you get across complex topics fast.
We sift through the information, find the core insights for you.
And today, we are plunging into something moving incredibly fast. Blood-based biomarkers for dementias. We're focusing mainly on Alzheimer's disease.
Yeah, it's a really hot area. Think of this as your quick guide to some super cutting-edge science.
Right, and we're drawing heavily from the Donald L. Price Memorial Lecture given recently by Professor Charlotte Teunissen.
She's a huge name in this field, heads the Amsterdam dementia cohort, really at the forefront.
And the lecture itself, the Price Lecture, it honors Don Price, who was, well, a giant in Alzheimer's research. So it highlights just how significant this work is.
Absolutely. Her lecture gave a really brilliant snapshot of, where things stand and where they're going.
So for this deep dive, we've basically got two main things we want to unpack from Professor Teunissen's talk.
Okay.
First up, the current situation with blood tests for actually diagnosing Alzheimer's. What can we do right now? And then second, we'll get into what feels like the really futuristic stuff, using these fluid markers to predict, maybe, who responds best to treatments and how we track if those treatments are working.
Yeah, the predictive and monitoring side. Super exciting. Our goal here is really to give you a clear sense of these breakthroughs and, well, why they're potentially game-changing for Alzheimer's care.
Okay, let's dive in then. First part. Plasma diagnostic biomarkers. It sounds like things are moving really quickly here.
Oh, incredibly quickly. Professor Teunissen really stressed that. She actually called one marker, p-tau217, the absolute winner.
Absolute winner.
Yeah.
Wow, okay, what makes it stand out so much?
Well, it's about accuracy, really. Compared to what we could measure reliably in blood before, p-tau217 seems incredibly good at picking up Alzheimer's pathology specifically.
Right, so it's a particular form of tau protein.
Exactly. It's phosphorylated tau, that's the P, at a specific spot, position 217. And that specific modification seems highly linked to Alzheimer's disease, more so than other tau forms we could measure easily in blood previously.
And it helps distinguish Alzheimer's from other, neurodegenerative issues.
Yes, that's the key advantage in blood samples. And it's not alone, I should say. There are other markers too, reflecting amyloid, reflecting nerve damage. It's about building a panel,
A panel, right, giving a fuller picture.
Exactly. A clearer view of the underlying Alzheimer's processes from a simple blood draw.
And you mentioned these are things researchers first found in CSF, the cerebrospinal fluid.
That's right. A lot of the groundwork was done using CSF, which is great, but, getting CSF involves a lumbar puncture?
Not exactly routine.
Not at all. So the ability to measure these accurately in blood, that's what makes widespread clinical use actually feasible. It's much less invasive.
And it's kind of amazing. The first papers on these specific plasma markers were just, 5 years ago?
About that, yeah. It's lightning speed for medical research, truly. It shows the incredible focus and, frankly, collaboration happening.
And it's not just lab work now, is it? Professor Teunissen talked about real-world studies.
Yes, exactly. At Amsterdam Medical Center, they're running implementation studies. They're looking at how these tests work in different settings.
Like in a GP's office versus a specialist memory clinic.
Precisely. From primary care right through to tertiary clinics, they want to see the actual impact.
What kind of impact?
Well, several things. How does it affect the healthcare system overall? Does it change how doctors actually make decisions? And really importantly, what's the patient experience? Does it lead to, say, a faster diagnosis? What do patients report back?
That faster diagnosis piece seems crucial. But she also mentioned some pushback, or maybe hesitation, from GPs in the Netherlands initially.
Yeah, there was some resistance. It wasn't all smooth sailing.
What were the hurdles?
Well, GPs could see the upside, potentially better talks with patients, maybe getting answers sooner. That was positive.
Okay.
But hindering factors were things like, well, the burden of adding another test and, crucially, a lack of really clear guidelines on what to do with the result.
Ah, okay. So you get the number, but then what? What's the next step?
Exactly. That clarity was missing initially, plus just the logistics of fitting it into a busy practice.
So it's the science, but also the practical side of things. Sounds like they put a lot of effort into the sample handling part, making sure the blood test itself is reliable.
Absolutely. They drew heavily on all the experience they already had with CSF samples, which also need careful handling.
Right.
So they did studies looking at, how long can the blood sit before processing? Does temperature matter? All those practical details.
And that led to standard procedures.
Yes. Working with the Alzheimer's Association, they developed consensus guidance, standard operating procedures to make sure results are reliable, no matter where the test is done.
And beyond just handling the tube of blood, There's the bigger picture of guidelines for using the test. You mentioned the WHO.
Yes, the World Health Organization is involved. They're developing what they call preferred product characteristic.
Okay, what does that cover?
It's basically a checklist for a good test. Like, what's its exact intended use? Who is the target population? How stable do the chemicals need to be? Is there technical support? Who should run the test? What training do they need? And, importantly, things like accessibility, affordability.
Right, making it practical for the real world.
Exactly.
And for these Alzheimer's plasma tests, the intended use is becoming clearer. Who are they aimed at?
Yeah, it aligns well with guidelines from groups like the Alzheimer's Association and the IWG working groups. Primarily, it's for people who are already showing some signs of cognitive impairment.
So not general screening for everyone, but for people where there's already a concern.
That's the current thinking, yes.
Yeah.
Using it where it's most likely to provide a meaningful diagnostic answer.
Okay, so huge progress on the diagnostic front. Reliable blood tests are becoming a reality, and work is underway to integrate them clinically. Let's shift gears to that second area. Using these biomarkers for treatment, predicting response, monitoring effects. This feels like the next level.
It really is. The core idea is that, well, not everyone responds the same way to a given treatment. Alzheimer's is complex.
Right.
So Professor Teunissen and others are looking at what biological factors influence whether a specific drug will work for this particular person.
And the obvious starting point is the core Alzheimer's pathology itself, amyloid and tau.
Exactly. You need markers for amyloid and tau just to know if someone is eligible for a trial targeting those pathologies, right?
Sure, makes sense.
But beyond eligibility, these markers can also show if the treatment is actually doing something biologically. She gave the lecanemab example.
The anti-amyloid drug.
Right. They saw that plasma p-tau181 levels, another one of these phosphorelated tau markers, actually went down in patients on lecanemab, sometimes quite quickly, like within 6 months.
So hitting amyloid seemed to affect the tau pathology downstream.
That's the interpretation, yes. It suggests the drug isn't just clearing amyloid, but might be influencing the broader disease process, which you can track with these blood markers.
Interesting. And there was also a link shown between long-term changes in plasma p-tau and actual cognitive decline.
Yes, they published work showing that over a 15-year span, people whose plasma p-tau levels rose more quickly also tended to have steeper cognitive decline.
So it really does track with the clinical progression.
It reinforces that link, yeah.
Yeah.
These aren't just abstract numbers, they reflect what's happening with the disease.
Now, beyond amyloid and tau, Professor Teunissen talked about digging deeper, looking at biological drivers, using some advanced tech.
Yeah, proteomics, specifically something called proximity extension assay, or PEA.
Okay, break that down a bit.
Think of it as a way to measure thousands, literally, like over 5,000 different proteins in a very small sample, like CSF or plasma. It gives you a huge snapshot of the biology.
Wow. And they use this to compare people.
They compared CSF from cognitively healthy older adults. Some had signs of amyloid buildup in their brains already, even without symptoms, and some didn't.
And even at that very early stage, before symptoms, they saw differences.
Yes, significant differences. In the amyloid-positive group, even though they felt fine, there were changes in proteins related to the immune system, protease inhibition-controlling enzymes, and also lipid metabolism, how the body handles fats.
So the disease process is kicking off molecular changes way before memory problems start.
That's what it looks like, and this kind of work led them to develop a specific panel.
The Clinical Progression Biomarker Panel.
Exactly. They identified 12 biomarkers from these proteomic studies that seem to predict whether someone, even if currently unimpaired or mildly impaired, is likely to progress towards dementia.
That could be huge for identifying people at high risk very early.
Potentially, yes, for planning interventions or future trials.
Professor Teunissen also brought up molecular Alzheimer's subtypes. This sounds like getting really specific.
It is. It challenges the idea that Alzheimer's is just one single thing. Her colleagues use CSF protein patterns to identify basically different biological flavors of Alzheimer's. They described 5 subtypes so far. Each seems to have a different main biological issue going on.
Like what?
Things like hyperplasticity, maybe issues with how brain connections adapt, innate immune system activation, problems with RNA regulation, issues with the choroid plexus, which makes CSF, or problems with the blood-brain barrier.
Wow. So 5 different underlying routes potentially leading to similar symptoms?
Kind of. And it suggests that maybe well, maybe treatments should be tailored to the subtype.
Right. That makes intuitive sense. Did she give an example?
She talked about subtype 2, the one characterized by that innate immune activation.
Okay.
Those patients tended to have the highest tau levels, the fastest brain atrophy, and generally the worst prognosis.
So for them, maybe an anti-inflammatory drug would be more effective?
That's the hypothesis, yes. Or maybe even anti-amyloid drugs might have different effects or side effects in that group because of the primed immune system. It really opens up personalized medicine approaches.
It really does. Now, you often hear that Alzheimer's doesn't happen in a vacuum. There are often other things going on in the brain, too. Co-pathologies.
Very common. Professor Teunissen emphasized this. Things like Lewy body pathology, the stuff you see in Parkinson's and dementia with Lewy bodies, or TDP-43 accumulation, or vascular damage. These often coexist with Alzheimer's.
And they complicate the picture, presumably, affect progression, affect treatment.
Absolutely. They can definitely influence how the disease unfolds and potentially how well someone responds to an Alzheimer's-specific therapy.
So let's take Lewy body copathology first. There's already a CSF test for that, right?
There is, yes. The alpha-synuclein seed aggregation assay, or SAA. It can detect the abnormal alpha-synuclein protein associated with Lewy bodies.
And if someone with Alzheimer's also has this?
Research shows they tend to decline faster, both cognitively and in terms of other biomarkers. But the SAA test is, well, it's basically positive or negative.
Binary. Not great for tracking subtle changes with treatment.
Exactly. You want something quantitative, a level you can measure.
Yeah.
So they use that PEA proteomics again.
Looking for markers for Lewy bodies.
Yes. And in CSF, from people with dementia with Lewy bodies, DLB, they found a significant increase in this enzyme, dopamine decarboxylase DDC.
Which is involved in making dopamine.
Right. Dopamine pathways are heavily affected in Lewy body diseases. And they validated this DDC finding with other methods in autopsy-confirmed cases and also found it elevated in Parkinson's disease, CSF.
So DDC and CSF looks like a good marker to distinguish DLB from controls or even Alzheimer's alone.
It showed good discriminatory power, yes.
Yeah.
And they even have some early clinical trial data suggesting its relevance.
Oh, yeah. What was that?
It was a phase 2 trial for DLB using a drug targeting phosphodiesterase 9. They found that the patients who have biological confirmation of DLB using a panel that included this elevated DDC marker seemed to respond better.
Better how?
Showed more favorable changes in some biological markers and maybe a trend towards better cognitive outcomes compared to patients who didn't have that biological signature.
Wow, okay. That's a concrete example of using biomarkers to pick the right patients.
It's a proof of concept, exactly. Showing how identifying copathology could guide treatment.
What about DDC in blood? Plasma DDC.
Interestingly, that behaved differently. They didn't see elevated plasma DDC at diagnosis in DLB or Parkinson's.
Oh.
But in Parkinson's patients after diagnosis, plasma DDC levels did seem to increase, and it correlated with the dose of levodopa they were taking.
So maybe not a diagnostic marker in blood, but a treatment response marker for dopamine therapy.
That's what it looks like for Parkinson's, potentially, which is still very useful.
But the hunt for a diagnostic blood test for Lewy body disease isn't over.
Not at all. Professor Teunissen mentioned another large proteomic study looking specifically at plasma.
Right.
They found a signature, a set of proteins, including things called endoglin, ITG, iascan, that were different in Lewy body disease. And this signature also helped distinguish Parkinson's from controls.
Getting closer to a blood test for DLB?
It's like it. A panel of about 7 of these plasma markers showed good ability to separate DLB from controls and even DLB from Alzheimer's. It's very promising.
Okay, that's Lewy bodies. What about the other copathology, TDP-43?
Right. This is a protein often seen in frontotemporal dementia, FTD, but also sometimes alongside Alzheimer's. They found a novel biomarker for it.
In CSF again?
Yes. Elevated in CSF of FTD patients who have TDP-43 pathology compared to those with tau pathology in FTD. High accuracy there.
And relevant to Alzheimer's.
Yes, because the same marker is also elevated in the CSF of some Alzheimer's patients. And when it is elevated, it seems to correlate with faster cognitive decline.
So another potential predictor of disease course tied to a specific copathology.
Exactly. Adds another layer to understanding individual disease progression.
It's incredibly complex. So all these markers, diagnostics, progression predictors, copathology indicators, the final piece is using them to actively monitor treatments.
That's the goal, yes. To have objective measures showing if a therapy is working on a biological level, the hypothesis is you'd look at changes in amyloid, tau, maybe these disease drivers or co-pathology markers.
Any early signs this works?
She shared one example, another proof of concept, from a trial of a drug called pepienmab.
Okay.
After a year of treatment, they saw significant reductions in several Alzheimer's relevant biomarkers, notably markers related to synapses, the connections between neurons. Things like neurogranin, SNAP25, GAP43 went down.
Suggesting the drug was having a positive effect on those vital connections.
That's the hope, yes. Indicating target engagement and potentially a beneficial downstream effect on synaptic health.
Okay, so let's try and pull this all together. We started with plasma, biomarkers. For diagnosis, sounds like they're almost here, especially p-tau217, with efforts focused now on implementation.
Right, becoming a clinical reality. Absolutely crucial, as Professor Teunissen said, for starting treatment.
And then this whole second part, using fluid markers to understand the individual's specific disease blend, predict treatment response, and monitor effectiveness. That seems key for the future.
Absolutely. She really emphasized that all these factors, the core pathology, the underlying drivers, the subtypes, the co-pathologies, they are all likely important for determining if a treatment will succeed for that person.
And we need panels of biomarkers, not just one.
Definitely. To capture that complexity, these markers need more testing in big trials, of course. Maybe some will become surrogate endpoints, but the direction is clear towards using biomarker panels to personalize and track treatment.
So wrapping up this deep dive, it feels like we're really on the cusp of a major shift in dementia care, particularly for Alzheimer's.
I think that's fair to say.
Blood tests making diagnosis faster, maybe easier. And then these fluid markers offering the potential for much more tailored treatments and ways to actually see if they're working biologically.
It offers a lot of hope, doesn't it, for more effective management down the line. It's a rapidly moving field, bringing real possibilities for patients and families.
It really makes you think, consider the implications for individuals, for families, for how we structure neurological care. And maybe it leaves you with this thought to ponder. How will all these biomarker advances, this ability to see the intricate individual biology of these diseases, how will that reshape our whole understanding of neurodegeneration in the next few years?
That's the big question, isn't it? A fascinating area to watch. Thanks for joining us for this deep dive.